Hello, this is Gary Heigl, and this is my presentation on situated cognition and the practical application of that theory to the training of paramedic students. In this brief presentation, I'll review the basic tenets of situated cognition, describe some of the techniques and approaches I use in training emergency medicine providers in my educational setting, and explain the strategy I recently used to put this theory into practice. Rooted in the theory of experiential learning, situated cognition is a theory that emphasizes the contextual influences of learning. In the late 1980s, Brown, Collins, and Duguid argued that learning is grounded in the situations where it occurs, and that the situations themselves are critical to the learning that takes place. For educators, this means that we can have a significant impact on learning by, at a minimum, being cognizant of the situations where we expect learning to occur, and even better, by strategically designing situations and creating environments that will support and contribute to our desired learning outcomes. Apprenticeship is a concept that has been widely recognized and appreciated in many trades for hundreds of years, and provides a great example of situated learning. Through demonstration, modeling, guided practice, coaching, and mentoring, the master passes on knowledge and skills to the apprentice. Cognitive apprenticeship is an example of situated cognition in practice. This idea demonstrates that the apprenticeship approach to learning that has been used so successfully in trades can be expanded to be equally effective in business, medicine, and many other fields. Alan Collins and colleagues created a framework of 18 key features involved in the implementation of this educational method. A table listing those features is at the end of this presentation and also attached as an appendix to my paper. This particular example of situated cognition ties in very well to my teaching environment. I am preparing paramedic students in the classroom for a field internship experience that heavily utilizes this sort of educational approach. In emergency services training at Rogue Community College, we are actively moving away from lecture-based classes and increasing our use of case studies, team-based learning, and scenario-based instruction. By doing so, we can create experiential learning opportunities that mirror the challenging situations that emergency providers face. A key component of making this approach effective lies in creating as much realism as possible. High-fidelity simulation in medicine is sometimes used to describe the use of sophisticated, high-tech mannequins, but this is only one use of that term. The Society for Simulation in Healthcare defines high fidelity as simulation experiences that are extremely realistic and provide a high level of interactivity and realism for the learner. While this can sometimes be accomplished with mannequins, I've found that well-coached actors or role players often provide the greatest fidelity and the best learning opportunities for our students. Students must interview and assess realistic patients, manage and treat illnesses and injuries, practice communicating with patients, with their partners, and with others unseen. In this process, every component of patient care can be simulated, including packaging and loading a patient, transporting and providing care in a moving ambulance, delivering the patient to a simulated medical facility, and providing a verbal report to the nurse or the doctor receiving the patient. For this assignment, I decided to apply theory to practice by building on the structure I just described and adding a new component. My two primary goals in this learning event were to develop and improve affective skills in my students and to increase awareness and appreciation amongst those students for the patient's perspective. These students were provided, the new aspect that this project introduced was to have students take turns in the role of the patient or family member in the midst of an emergency so they could experience a simulation of the event from that perspective. These students were provided a story with appropriate medical details, but not a specific script. Students in these roles were encouraged to imagine themselves in the situation described, in this example, a case of heat stroke, and to the best of their ability, react in ways that they believe they would in that circumstance. One of the most challenging and stressful situations emergency responders deal with is pediatric resuscitation. In this scenario, a small child was found in the bottom of a pool, and the rescuers must manage the care of the child. One of the students in this scenario was assigned the role of the patient's mother, who comes home 3 minutes into the rescue effort and discovers this situation in her yard. In the process, one student is imagining herself in a situation that's every parent's worst nightmare, and the other students must manage the mother on scene and also continue the resuscitative efforts, now dealing with the added stress of an anguished parent. In this image, you can see several things. In the background, one of the team members is attempting to console and control the mother. The rest of the team is continuing to work on the child. And in the foreground, you can see that another student who is not a part of this particular scenario is capturing all of it on video for later review and reflection. This is relevant because much of the literature on experiential learning in general, and on situated cognition specifically, emphasizes that a huge part of our learning occurs through reflection. Situated cognition, in examples such as this project, provides opportunities for reflection in action, which is that learning that takes place as the events occur. This brings us to another critical component of this learning approach, which is the debriefing process. There are additional learning opportunities that occur through reflection on action. Instructors who are experts in the field act as facilitators, and an effective facilitation encourages student reflection on the experience, coupled with active discussion about the thoughts, feelings, decision-making processes, and the outcomes. All participants in the scenario are encouraged to contribute and to share their perspectives. In the process, learners explore many alternative decisions that could have been made and benefit from the expert input of the facilitator, as well as the perspectives of the patient and the family members involved. Through this reflection, discussion, and coaching, students are provided a framework for constructing new meaning and applying new knowledge in complex and difficult situations. By including the perspective of the recipients of care, students also gain an awareness and appreciation for how their effective behaviors as providers may impact the emotions and the reactions of others. On completion, students are assigned different roles and participate in additional scenarios. Each subsequent scenario is an opportunity to apply the lessons learned, to explore new approaches, and to complete the debriefing and reflection process again. My first attempts at this approach have been very well received by the students and appear to be effective in broadening their perspectives. I look forward to incorporating these practices regularly in our training in the future, as well as finding additional ways to apply these theories to my practice. If you would like to discuss this or have questions for me, feel free to email me. My email address is at the end of this presentation, and thank you for your time and attention.